Welcome, everyone, to the second day of our summit. I'm Linda Resnick, the director of CoHSTAR and LeaRRn, and I welcome you to the second day. Before we begin our activities, I want to again acknowledge the funders of this event, NCMR, NINR, the Foundation for Physical Therapy Research, and APTA, and we're sincerely grateful for your support. And I also want to thank again the planning committee members, and give a special shout out to my logistics team, Mary Slavid, Lisa Juckett, Maggie Witten, Kara Jackman, and Courtney Hawes for your help in managing this complex hybrid event. I think you can all agree that the planning committee did a really great job in sequencing the content for this event, and I think today's last session will be a great culmination of that sequence. I wanted to remind you that each session will have a moderator. For audience members, as we did before, we want your input with your questions and answers in the Q&A features if you're on Zoom, and if you're in person, with your thoughts and comments on the Post-it notes on the walls. And we have assigned, again, to this session, a synthesizer who's going to have to work quickly to help synthesize the findings from this, the key takeaways from this session, to share in the breakout groups, which will be happening after this session for in-person attendees only. So at the breakout groups, I'll remind you that there will be active audience participation. Your breakout group assignment is on the back of your name tag if you're in person, and there's a recorder for the breakout groups who will be taking notes, and we will also record the sessions so that we have detailed notes. Our hope after this summit is that we do some extra synthesis, gathering input from all the participants, and create some work groups to bring the work forward to the next level with some sort of products for reporting out and dissemination. So if you're interested in being part of that initiative, please scan this QR code, sign up. Let us know which particular focus area you're interested in reporting on. So now I'm pleased to introduce the moderator for this session, Dr. Brocha, who'll assist us in moderating this session. Brocha is assistant professor in the Department of Orthopedic Surgery and the Institute for Healthcare Delivery in the Department of Population Health Science and Policy at the Icahn School of Medicine at Mount Sinai. She is a health services researcher and a LeaRRn scholar at Intermountain Health. She has a particular interest in clinical applications of patient-reported outcomes measures to support high-quality, person-centered, and equitable care. So, Dr. Stern, I'll hand it over to you.
All right, well, thank you, Dr. Resnick, and good morning, everyone. I hope you had a little bit of time to digest all of that incredible content from yesterday. I know my mind is still percolating, but it's my privilege to moderate this session on using data to inform care. We have 4 outstanding panelists for you. We have Dr. Mary Stilphen, Dr. Jason Beneciuk, Dr. Joshua Johnson, and Dr. Patricia Grady-Dominguez, who I'll introduce in just a moment. Wrong way. Oh, wrong way. There we go. So while this session is positioned last in the series of panels, and that's partly because we need to have some level of maturity and some of the things we've talked about earlier to actually get to the uses, it's really important for us just to reflect on the fact that what we're talking about in this session are really some of the whys that are driving the entire process. So having some clarity and vision in terms of, how you intend to actually use that data at the end is really important in making some of those earlier decisions about selecting, capturing, building that infrastructure to access, analyze, et cetera. So when we talk about using data to inform care, well, we can think about this on a continuum from the population or system or organization level, all the way to like that individual clinician-patient dyad at point of care. At the organization level, it can be things like value-based contract negotiation, value-based payment, which you heard a little bit about yesterday. At the practice level, it can be, using data to try to, reduce unwarranted variation in care. At the clinician level, it might be feeding data back to an individual clinician in order for them to make more informed care decisions about the patient sitting in front of them. And there may be instances where we're even feeding data back to the patient and or their family to help them, better engage in their care and facilitate shared decision-making. So we're not going to cover the entire full spectrum of use today, although we would have loved to. But we tried to select for speakers and for topics within this, which can kind of give you a little bit of that breadth. So our first panelist is going to be Dr. Mary Stilphen, who's the Senior Director for Cleveland Clinic Rehab and Sports Therapy. Over the past 14 years, she led the integration and consolidation of rehab services across a large health system consisting of 11 hospitals, 70 outpatient therapy centers, and over 1,400 therapy professionals. She led the effort to establish a system-wide standardized approach to the collection of PROs, and featured in this effort was the development of 6-Clicks, which is now widely used in acute hospital settings across the country. So Dr. Stilphen will be starting off this panel with thinking about the organizational level. Next, we're going to have Dr. Jason Beneciuk, who's a research associate professor in the Department of Physical Therapy at the University of Florida and a clinical research scientist at Brooks Rehab. He's been supported by the NIH, PCORI, CoHSTAR, and the Foundation for Physical Therapy Research. You already met him yesterday. So I'm going to abbreviate the rest of the bio, but he currently serves as an associate editor for for Physical Therapy and Rehab Journal, PTJ, and an international editorial review board member for the Journal of Orthopedic and Sports Physical Therapy. In 2021, he was the recipient of the Eugene Michaels New Investigator Award by APTA, and he's also a current CoHSTAR faculty fellow. And he'll be presenting on using data to identify areas for practice improvements and thinking about this more on the clinic or practice level. Next is going to be Dr. Joshua Johnson, who's a physical therapist researcher with appointments at the Duke University School of Medicine as an assistant professor in the Division of Physical Therapy, Department of Orthopedic Surgery, and Department of Population Health Sciences. He's also the clinical research lead for the Duke University Health System Department of Rehab and a member of the Duke Clinical Research Institute. His work seeks to better understand and improve rehab care delivery using the learning health system framework with overlap between data science and implementation science. And prior to joining Duke, he was the director of payment or outcomes research at Cleveland Clinic. His PhD training was at the University of Utah, and he holds a DPT degree from Arcadia University and a bachelor's degree in athletic training from Brigham Young. And he'll be presenting on using the data at the clinician level, specifically about the design and implementation of a point of care decision-making tool. Finally, we have Dr. Patricia Grady-Dominguez, who's an occupational therapist and rehab researcher specializing in measure development and validation. After earning her PhD from Colorado State in 2022, she began a postdoc where she's focused on integrating her passion for measurement with a vulnerable population, children with disorders of consciousness. She's committed to leveraging assessment data to enhance rehab outcomes and emphasize the importance of data transparency and comprehensibility to patients, clinicians, and families. Her work also seeks to understand how nuanced assessment data and insights into recovery trajectories can influence clinical decision-making. And she'll be presenting on using data to inform patient-centered decision-making, including feeding data back to patients, or in this case, families. So I'm really looking forward to hearing from these outstanding panelists, and I welcome Dr. Stilphen to the podium.
Now I got to figure out the slides. Am I going backwards? Oh, here we are. Thank you so much. I'm really excited to kick this off this morning. Yesterday was so great. So we got to DC, my colleagues and I, a couple days ago on Monday. We had the opportunity to explore around the area, and we went to some of the museums, and we went to the Renwick, one of the Smithsonian museums. And hanging in the gallery was this large sign, this large neon sign, and it says, "This present moment used to be the unimaginable future." And so I thought about that. This present moment used to be the unimaginable future. And when I think about where we started, where I started in, 15 years ago, talking about PROs, never thought we'd all be here in a room together, thinking about how we use patient data to make our patients' lives better. So here we are, a little bit about the Cleveland Clinic. We are our largest health system. Brocha went over it, but now we are up to 18 hospitals and 80 outpatient clinics and about 1,500 caregivers. And we do lots and lots of patients' visits and have the opportunity to collect a lot of patient information from them about how they're doing. So our journey utilizing patient-centered outcomes really began in about 2012, and it's been a journey. We really didn't know what we were getting into when we started to think about patient-centered outcomes. We had the ability to start to collect discrete data through a EMR that we were using at the time called MediLinks. And we saw this as an opportunity to start to capture data from our patients about our patients. We knew we wanted to develop some kind of tool, and we didn't really see anything out there that we wanted to use. So we found a tool. We knew we wanted something that would be minimal burden on therapists. Again, people talked about that yesterday, minimal burden on staff, just a few questions, and something that we could incorporate into our current workflow. Our goals were to collect meaningful, discrete outcome data with every patient encounter, utilize that data to help us drive clinical decisions, to demonstrate the value of us as therapists, and to help us guide resource utilization, because that was in 2012, that was a big deal. Also, we wanted to use this data to develop a more objective way to help us determine where patients should go after their care in the acute care hospital. So if you think back to 2012, those of you who are practicing therapists, most of our role at that time was really to make discharge recommendations for post-acute placement. We really didn't spend much time in treating our patients. So we worked with Alan Jetty at Boston University and developed this tool we called 6 Clicks. And it's a short form of the MPAC. And I wish I could say that we sat down and developed consensus and thought about the questions that we should ask, but we didn't. Sandy Pasek, Karen Green, myself, Dr. Fred Frost, sat down with a 254 question item bank and picked the 6 questions that we thought made the most sense. It did what we wanted to do. We wanted to incorporate it into the workflow. So we thought about the trajectory of evaluating a patient. What did we do? We looked at how they turned over in bed. We looked at how they got to sitting, how they stood, how they transferred, how they walked, and how they climbed stairs. Same thing with activities. We sent the questions back to Alan. There were the 6 items we had developed. He said that they met the psychometric, properties. Made one change and sent it back to us. We had a staff meeting. We brought pizza in for the staff and we said, hey, how about this? We're going to start collecting this on every patient eval. We're like, great. And so that was it. Put it in the EMR and we started data collection. We didn't know a lot about patient-reported outcomes at the time, but we knew that they could be used on an individual patient level. We could screen for clinical problems, identify limitations. We could monitor progress over time, or help, communicate with the patient about goal setting, or we could use it on an aggregate level to use it to inform quality improvement, conduct population monitoring, and to drive system change. And that's what we had initially, that was our initial goal with the tool, was to use it to help us drive system change for problems that we were facing at the clinic. So again, uniform data collection, use that. Everybody in the entire health, really we started at main campus. Every therapist at the main campus collected this information. There was no question about if they were it was just part of the EMR, became part of their workflow. We use that information to help us make system decisions. And again, it really helped us that Alan had told us from the very beginning that he did not think this tool was sensitive enough to change to be used on the individual patient level, and that the way we were going to have to use it was on the aggregate level. He also never thought he'd hear from us again. He thought we were going to develop this tool and that was going to be the end of it. He never thought it was going to work, but we were pretty determined. So this was our first plot. This is what it looked like when actually, this isn't the first, but they haven't changed. So this is a couple years into it, and this was the distribution of scores, right? What does it look like? And this is really all we had. We had on eval, this is the distribution of scores, ranging from 6 to 24. I'm also going to tell you that those of you who know the AMPAC, there's a scale of 0 to 100, and that this short form is just a slice of that scale. So the ranges are, Josh, from what?
About 16 to 50.
From 16 to 54. We made a conscious decision at the Cleveland Clinic that we were going to talk about it in the acute care hospital with the raw score only, because that is the only way that we were going to get any traction with this. If I could talk about a patient that was a 6, people could visualize what that was. If I said it was a 16.82, nobody would understand that, right? So the score of 6 being our low functioning patients, 24 being those who are pretty much independent, would meet us in the hallway, really caught some traction within the medical teams, nursing staff, the other teams at the Cleveland Clinic. So again, if you don't know how to ask the right question, you discover nothing. So what questions could we ask based on that distribution of scores that we saw? So we came up with 3 that were really important to us. One was, how could we use that to help us guide discharge recommendations? How could we use it to improve patient mobility? And how could we use it to guide therapist resource utilization? So our patients that had a high score of 24, we spent a lot of time with them, and I'll talk about that briefly. But look where they went. Most of them had absolutely no needs. A few had most had no needs at all. Some had home care needs, some had outpatient therapy needs, and a couple, there are people that are high functioning that do need acute rehab, so some went to acute rehab. But this was continuous. This is what we would see from our patients that were high functioning. We had a lot of patients, about 25% of our caseload had 6-click scores of 23 or 24. So we knew we had a problem that we had to tackle. It probably is not unique to the Cleveland Clinic. I bet that happens a lot of places, right? Consults get put in, but now we had a way to measure it. We shared that information with our referral sources. We talked about the cost of that, the cost of the potential waste, right? We could have spent our time with patients who really needed our care, but we were chasing these consults for patients that really did not need us. And again, we talked about we've talked about it for years, actually. And then we looked at this distribution and we thought, how ideal were some of those higher functioning patients to get nursing or other members of the medical team involved with mobilizing them, right? In 2012, it was primarily the therapist's responsibility to mobilize every patient in the Cleveland Clinic. We had a physician who would say there aren't enough therapists in the state of Ohio to take every patient in the Cleveland Clinic for a walk. But that was thought of it, that was our role. So we use this information to help to engage other members of the medical team, patients' families, whoever, to help us to mobilize patients. We also used it for discharge planning, we did a little bit. We got to see the relationship between patient scores and where we recommended they go and where they went for post-acute care. So you could see that our highest functioning patients hit a score, the patients that went home averaged about a score of 20, and you can see how that went down. What we always found interesting was that patients that went to skilled nursing and acute rehab had the same function, but the same basic mobility score, but yet they had different needs. And I think somebody talked about that yesterday, like, how do you know this is just the right measure? And we just kept saying, this is just one piece of the puzzle. It's not the whole patient. It just talks about their mobility. There's the other domains. There's their cognition, which we didn't talk about, their psychosocial environment, all those other things that play into decision-making with therapists when they make recommendations. So we held on to this information for a couple of years, and I don't know that we knew what to do with it because we were all just clinical operators. We didn't have any research components until I think I socialized it here. I think Stephen Hunter, you were at a group with a health system rehab community at the APTA, and I started to talk about it, and they were like, that's kind of a good idea. That's kind of a cool tool. You should talk about that. So Allen Partners brought Diane Jetty, and we partnered with her, and thank God for her because she is really the one who helped us. She was the research component and the research person that we needed, the partner that we needed to publish this information. So we published 3 articles rather quickly. She was supposed to go on a sabbatical and said she came to Cleveland Clinic and spent a few months with us. And we validated the tool. We looked at its usefulness for post-acute placement, and we did an integrated reliability study on it. And so once that got into, once we published that, that really got the tool going. And again, this is the one we published on discharge destination. Another question that came up yesterday was this, could this ever be misrepresented? And this information has been misrepresented by insurance companies, by consultants a lot. Because all we said that was that if you had a score of around 18, if you were more likely to go to an inpatient setting if you were below that cutoff score, and more likely to go home if you were above it. That's all. There was not that this was a hard line. It was just the likelihood of going to those locations. And it has been used by payers and by consultants that this is a kind of a hard stop. So I do caution that we do have to be careful about this information. Then from 2016 to 19, things changed a lot because Josh came to the clinic. What year did you come? 18. So we had all this rich information. We had published a little bit, and we were kind of sailing along. And then we had a health service researcher who was interested in coming to the Cleveland Clinic because we had all this rich data that we could use. And it really changed the way it helped us tremendously. And so we changed our efforts to align with what the goals of the organization were. And so we had an initiative where we sent patients to SNF without a pre-cert. We all know the administrative burden of having to do a pre-cert for every 48 hours to send a patient to a post-acute setting. They were using our 6 clicks information and would transfer them. Then the tides changed and we didn't want so many people to go to post-acute. We wanted them to go home. So we used this information to change that trajectory and figured out how to use it to get more patients home. But all initiatives were done using 6 clicks data. Then with Josh there, we hired a continuous improvement leader. And that is really what I know Josh is going to talk about a learning health system and the cycles of that, but that is really what closed the loop for us, is that it changed the way we looked at addressing complex problems. We knew that data was imperative to continuously improve. We use data to identify our baseline state, develop targets, to identify our improvement efforts, and really employed that PDCA cycle. This is some of the data. We drove data down at the clinical level. We made it accessible to them, understandable, easy to interpret. Josh was instrumental in this. He helped us develop, I'm going ahead. Our most recent, our current projects are really looking at getting to the right patient at the right time, which is really at the crux of what we want to do. We're still looking at increasing hospital mobility, and we're still looking at decreasing therapy consults for high functioning patients. But now we're really using continuous improvement to help us with these efforts. Josh helped us develop a couple of dashboards called, this is the V-Dash. And for me as a clinical operator, this looks fantastic. It looks like on the bottom graph, on the bottom left, we have our low functioning patients, and you can see by their grouped by 6 click scores and the number of visits that they get while they're in our care. And so you can see we're now targeting our interventions to the patients that need us the most, our patients that are low functioning, and not spending hardly any time with our patients that are high functioning. So to me, this is really a success that you can see that we've been able to use this information to guide the therapists the way they provide care. So fast forward, we're now using continuous improvement to do some of the same things that we've always been doing. We've been trying to engage nursing and mobility. Danny Young talked about their program, their AMP program, and how well they do at getting nursing to collect 6 click scores and then guiding mobility. We have done the exact same thing. Nurses all throughout the entire Cleveland Clinic health system capture that data upon admission and daily, and they use the JHHLM, and that helps drive the mobility program. But we've been able to get that process to stick. And probably what I'm the most proud of is that after 10 or 12 years of showing data of our high functioning patients, we are getting a hard stop in Epic that will stop a consult if a patient has a nursing 6 click score of 23 or 24, unless they can type in a medical reason to override it. Because we all know that there are some high functioning patients that do need our care, but it will help us to eliminate some of the waste that we had. So lessons learned. I don't know where that text is. We had a lot of lessons learned. It's so weird. we learned never to give up, just to keep trying to keep moving forward. And just the power, and we all know this here, that the power of data, how important that was to help us make clinical decisions and really demonstrate the value of what we do. So we never give up. I mean, you can see we've been at this high functioning patients and, decreasing our consults for 12 years, and we're finally there. But it took us a long time. And so to get through the hardest journey, just take one step at a time, but you gotta keep moving forward. So thank you.
Thanks, Mary. And I'd like to thank Dr. Resnick again and Brocha for inviting me to participate in this session. So thank you both. I met everybody yesterday. So I'm Jason Beneciuk, affiliated with University of Florida and Brooks Rehabilitation. And, when I was kind of invited to talk at this session with the focus being using data to inform care, I kind of thought about some of the things we've done in the past and something that I'm really excited about that we're kind of maybe more than in the middle, but we recently completed with using our data. And I thought this was important and relevant to this conference because, those of you that are involved with kind of, working with clinicians and asking them to collect these types of measures, one of the real questions we always get from them, and I've been receiving a lot of those questions recently, is, we're collecting this, right? Our rates are really high, but, what are we doing with it? Okay, so this is just one example of quote unquote what we're doing with it. And I remind them, it took a lot of time for us to kind of cover the things that were really talked about in session A, B, and C yesterday. It took us a lot of time to kind of, determine what measures we're going to collect, to actually set up an infrastructure to collect them. And then we had some things that happened in 2020 that, Maggie, what's the term we used last night? Operational prioritization. Am I saying that right? Yeah. Things got put on hold. So things take time. And, we try to stress that, you need to understand that. So let's get into this. This is a slide that I actually had yesterday to kind of set the stage for the session that I moderated yesterday. And I think this is important because this is part of the value proposition, right? A really small piece in terms of selling this to clinicians. Clinicians understand the benefit of using these measures, including patient-reported outcome measures, but we all know, and they know that it's challenging, especially because it's challenging to not only administer them, but what do they do with that information? What do people like me and others in my organization do with that information, that data, to help them improve their clinical practice? Mindy showed this slide yesterday, so I'm not going to get into great detail about the Brooks system, but I will tell you what I'm going to talk about today really focuses on on our outpatient division. So this is a timeline that I'm kind of proud of because I think a talk like this kind of forced me to develop a timeline like this and kind of tell our story. Or maybe I did this for my CoHSTAR application, CoHSTAR fellowship application. But this really kind of, tells the story from the beginning to the end. And like Mary, what they did at Cleveland Clinic was, close to 15 years ago, maybe over 15 years ago. We started this process in 2011. And I think we actually started maybe the year before when I was still a PhD student and met with Brooks leadership to kind of, put this on the table. This is something we should be doing in the system. And as you can see, the timeline goes from 2011 to 2023, and we have a few years up there that are red, right? 2012 to approximately 14, Brooks participated in a bundled payment project. So the priorities in the organization weren't on collecting patient-reported outcomes in the outpatient division for orthopedic patients, which is understandable. 2020, we had something happen that also kind of put things on hold a little bit, so we don't need to talk about that. But where we are now is in a good place. And, what I'm going to talk about really today is some of our meetings that we've had with our outpatient clinics. We have over 50 outpatient clinics in our organization. And what we recently completed was we basically met with half of them, with half of our clinics in the system. I think I might have showed this last year when I did a presentation for this conference, but just a quick glimpse at our dashboards. So this is what our clinic managers and all of our clinicians have access to. They have access to look at their patient-reported outcome measure scores, There's a lot of different tabs up top there, so they can kind of filter it by their clinic. They can filter it by specific body region. They can compare their clinic to the rest of the outpatient division. They can look at it at just their own scores, so at the clinician level. There's a lot that we can do here, all right? And as you can see here, the numbers there, so for, what would that be, May of 2021 in that case, that would be the capture rate for that particular clinic in that month. We also have the same types of dashboards for follow-up capture rates. And then we also have what we call, and I don't really like this term, but success rates, okay? We have to use a term to kind of describe patients are meeting a benchmark or a threshold. And we kind of started with a threshold of 10% improvement from baseline. That's what kind of leadership and outpatient clinicians agree to would be a nice place to start. Now, I think if you look at 10% improvement from baseline, some of you might say, well, that's not really that much of a significant improvement, clinically important improvement, but we had to start somewhere, okay? So that's where we are, that's where we started. We also have leadership. This is part of engagement. Leadership kind of, disseminates this information to the whole outpatient division on a monthly basis. So in terms of being transparent and the kind of, friendly competition, if you will, all the different outpatient clinics know where they stand in terms of capture rates, success rates, across the board, what have you. So like I said, what I'm going to really focus on is our meeting to really identify positive behaviors from our clinics in the system. So how did we go about doing this? Well, we kind of divided clinics into two different groups, and the different groups were really based on those success rates. So clinics that had a greater than 60% success rate, or said another way, greater than 60% of those clinics achieved a greater than 10% improvement, which in the grand scheme of things, right, 10% improvement, like I said earlier, isn't a lot. But we needed criteria to kind of select. We also had other criteria. We wanted to make sure the clinics that we met with had a reasonable number of episodes for the body region of interest that we were meeting with them, and that they had a decent number of capture rates too. It was about 50%. So what we did is we met with 8 clinicians, eight clinics that consisted of approximately, 20 or so clinicians, and there you see their success rates. So all their success rates for those different patient-reported outcome measures were above 60%. We asked them various questions before we met with them in person. And you'll see these questions really stem around clinical practice, clinical decision-making, but I also started off with a general question of, why do you think you were selected to meet with us to have this conversation? We also had stakeholders in our organization to kind of help summarize the results that we got from these focus groups. Some of these stakeholders wore multiple hats, right? Some of them were in outpatient leadership, but also still treated patients. So they represented outpatient leadership and clinicians. But we had a total of 6 individuals to help us kind of summarize the information that we gathered. And the ask was that they identify 2 to 3 common themes from responses to each of those 6 questions. And then they also provide 2 or 3 major collective themes based on all the responses. So for the first question, general thoughts, and again, this was for the group that was doing well, right? They were doing well in terms of their outcomes. We asked them, why do you think we selected them? And the responses were basically summarized in terms of they do a good job with communicating. They do a good job communicating between each other and with their patients. That was a common theme. And the x-axis really represents times that theme was brought up by the individual clinicians in the clinics. We asked them about prognosis and their clinical decision-making and what was important in terms of helping inform their prognosis and clinical decision-making. And you see on the bottom, the most common theme was patient expectations. And patient communication and education kind of came up second there. The question about if treatment is effective or needs to be modified. This topic came up yesterday in one of the talks in terms of, what happens from intake to discharge? Well, a lot happens. Decisions need to be made, and we kind of asked them about, what kind of drives this? And it was a combination between subjective reports, patient-reported outcome measures, and other impairment-based measures. And then finally, this is kind of probably I think the other questions are relevant to this conference too, but this is probably the most relevant. What do you do with these patient-reported outcome measures that we've been asking you to track over time? And the common response was the general theme had to do with using them as a conversation starter with their patients. Which I thought, going into this, if I kind of, what would be my pie in the sky dream in terms of what clinicians would tell us, it would be something kind of related to this, that they're not just using them to track scores and interpret numbers, but they're using them to engage their patients in meaningful conversations. So this is what they told us, not what I'm telling you. And then our major collective themes from our stakeholders, I'm not going to read all of these, but you can kind of look at them. These were some of the comments that they thought and they kind of took away in terms of major themes from this. And, you'll see the one in the top right has to really deal with creating a culture of clinical excellence, right? This is really part of that. Communication, patient and clinician communication, clinician and clinician communication was also a really common theme with this group of clinics here. And again, here you see other major collective themes that were kind of presented by our stakeholder group. So again, we were trying to identify positive behaviors, positive perceptions, positive attitudes from this group that really are doing well in terms of patient-reported outcome measures and the improvements they get with their patients. Because remember, we also have that other group that aren't doing as well, right? So can we use this information to help educate some of those other clinicians in those other clinics? So that basically would be the next steps. And just last week, we actually, I guess when the chat comes up in the bottom, it throws off the system here. But we just completed meeting with the other group of clinics, right? So these are clinics that weren't really doing so well. And you could see in the bottom right there, their scores. So there's a pretty significant difference there in terms of improvements, right? 30% improvement from the prior group. They had like 60% improvement or 60% scores here. So there was a drastic difference in the clinics that we selected. And like I said, we didn't have time to analyze that data yet before this conference, but you'll see here we do have an equal number of clinics and around the same number of clinicians. And I will tell you, in just kind of looking at the data on a preliminary basis, one of the common things that came out to me was, when asked them why that we contacted them for this this focus group meeting, a lot of those clinics that weren't doing as well said, well, you're meeting with us because we're doing really well, because our patient-reported outcomes are probably the best in the system. So, that was a real key message to me that we can talk about during the Q&A, but it kind of hit me in the face. And, I'm not going to say I was happy to hear that, but I was happy to hear that. So, closing thoughts here is, this is another way for clinicians to gain some value for using these patient-reported outcome measures, and that they're more than just tracking or collecting what we're actually doing with this. So there is value to this. And again, we will hear later, especially in some of the breakouts and probably even later after that, is this whole idea about value proposition. And this is one thing that our patients told us in prior projects is, they understand and understand the importance and value communication, but they also think that it needs to be improved in healthcare. And that's not just in rehabilitation, but it's really, between providers and patients, and also between providers that treat those patients. So with that, thank you.
Good morning. I am really grateful to contribute a small piece to this excellent discussion we've had over the past day plus by talking to you today about the PT pencil as an example of using data now at the clinician level. A few acknowledgements. First to LeaRRn and to Linda that funded this project as a LeaRRn Pilot Award, so thank you. Also to collaborators at Cleveland Clinic, Mary Stilphen, who you already heard from in this session, Sandy Pasick, who's here in the room, a statistician, Brittany Lappin, and one of our full-time PTs, Valerie Ass. At the bottom of this slide, you see the names of our learning community partners. You'll learn throughout this presentation that we could not have done this work without them. And so I wanted to make sure we acknowledge them as well. This is probably not an exhaustive list, but these are the things that, for me and the work that I do, are keys for using data at the level of clinicians. First, there needs to be a shared purpose between organization and clinician. That's our why. There needs to be the organizational capacity to do this work, and there needs to be a framework for the co-creation of solutions. We've heard a lot about these yesterday, and so my purpose today is to kind of describe briefly what I mean about these in the context of using data at the clinician level, and then walk through each of them again with the PT pencil as our example. I would argue that in today's climate, I hope, as we continue to march slowly towards value-based care, that value-based care is a great purpose to rally around for organizations. This is a fantastic framework proposed by Porter and Lee, the 6-component value agenda. What you'll note here, though, is that these are organizational type priorities. These are things that organizational leaders should care about. And remember what I said, the key for using data at the clinician level is making sure that there's a shared purpose between clinicians and organizations. So we need to think about this a little bit differently. So let's look, for example, at number 2 here in this value agenda. Measure outcomes and costs for every patient. Again, a health system leader needs to figure out how to do that across their system. But clinicians care about helping patients get good outcomes. Look at number 5, expanding excellent services across geography. That is not the job of an individual clinician. However, clinicians do care about consistently providing excellent care. Number 6, to build an enabling technology platform. No single clinician is going to take that on. However, clinicians like technology. As one clinician told me, it just can't be dumb. It can't take up more time, and it needs to be useful. It actually needs to contribute to my ability to provide care for my patients. So value really is, in my mind, a really great unifying purpose for clinicians and organizations. I won't talk really at all about this because we heard all about this yesterday about the organizational capacity. I really appreciated what Dr. Kozlowski said yesterday at the end of our session, which is if you don't get all of this right, then you're probably not going to be able to do a lot of using data at the clinician level. So there has to be building blocks here. And the way I've conceptualized that is you need the right people with the right tools to get the right data in and the right data out. What I will call out on this slide is here in italics about clinical decision support tools, which is one form of getting data out. And I highlight that because that's what the PT pencil is. It's one of those prescriptive algorithms that we learned about yesterday. Third, a framework for co-creation. I've really bought into this Friedman model of learning health system cycles. Pretty much all of the work that I do, as Mary talked about, involves these cycles of improvement. Key to this is the formation of a learning community. And when Dr. Friedman talks about this and writes about this, he highlights that as an absolute critical component of these learning health system cycles. A learning community are partners with a shared interest in the health problem that you're trying to address and complementary expertise amongst them in order to help solve that problem. Another key component of this learning community is that everyone in the learning community participates in every phase of this cycle. You don't leave anyone out and you don't assign tasks to one but not the other. So that's what we attempted to do. So let me talk about then all of these keys in the context of the PT pencil. The PT pencil is the physical therapy frequency clinical decision support tool. We use some creative license to find all the letters for that acronym, but they're all there. The PT pencil is really built as a clinical decision support tool for therapists in the acute care setting in order to identify the patients that would most benefit from their care. So let's talk about the shared purpose between organization and clinician. Again, this is about value. In order to increase value, we can improve health outcomes that matter to patients. For acute care physical therapists, some ways that they might do this are to help patients improve their functional independence, or at least contribute to them not getting worse during their hospitalization. They may contribute to shorter hospital length of stay, which patients care about. They may contribute to having patients on ventilators or other complex medical equipment for a shorter period. Patients care about that. They may help more patients discharge home, which is what most patients want. Ironically, a lot of these things also help us address the denominator of the value equation, which is decreasing costs. All of you who work in hospitals know that the bottom line is affected by length of stay. So if the therapist can help decrease length of stay by whatever mechanism, that's a win. Therapists can also help patients use fewer costly resources like ventilators or days in the ICU. Perhaps a little bit controversial in this group, hospitals can also save money by having fewer therapists. And they do that. And that leaves us with this problem where we have not enough resources to care for all of the patients that are on a PT's caseload. And it's that context where the PT pencil lands. This also helped. This was actually my LeaRRn-funded scholar project where we looked retrospectively across 11 Cleveland Clinic hospitals and identified a trend. Across all those hospitals, as patients received more frequent physical therapy, the likelihood that they achieved a discharge home and improved function, and both of those outcomes occurring together, increased. So what we did not conclude from this is that every patient needs more PT. That's probably not true, and it certainly doesn't fix our value agenda problem. But what we did identify is that there probably are patients across Cleveland Clinic hospitals who could benefit from more frequent PT in order to discharge home, which was one of those key outcomes, and maybe they weren't getting it. So we still had a problem we needed to fix. So we needed to know what are the characteristics of those patients and how do we identify them in real time so we can do something about it clinically. I don't need to talk about this either because Mary described to you that we had the organizational capacity to do this. She helped to develop it over years before I got there. So we had everything we needed to start using data at the clinician level. So when we talk about the framework for co-creation, let me introduce you to our learning community for this particular project. This included our study team, me as the researcher, our biostatistician, and Sandy Pasek here in the room as our rehab informaticist. We also identified 3 hospitals in the Cleveland Clinic system where we expected to be able to implement the PT pencil. And so from those hospitals, we included the rehab manager and 2 frontline physical therapists as part of our learning community. And then at the appropriate time, we engaged an analyst from our electronic health record to be able to do that last piece of the data out that we couldn't do on our own, but that he could help us with. This is a complex figure. I would direct you to the citation here. What this shows, though, is the work of our learning community. And so if you're interested in understanding the details of that, please go see this paper. What I want to call out from this figure are 3 things. 1, we had a very clear problem of interest to identify the patients that were most likely to benefit from physical therapist interventions in the hospital. Then we decided we were going to work through 2 cycles of this learning health system cycle together as a group. The first was to develop the PT pencil for integration into the electronic health record. And the second was to conduct a small study to understand the effect of its implementation. Guided by our problem of interest and an established goal, our first step then was to develop the PT pencil by first considering a statistical model. Again, this was meant to be a prescriptive model, something that led to some clinical action. So the basis of that was a predictive model. We needed to predict the outcome that we wanted to achieve. And so we spent several meetings over months with our learning community considering what do we want that outcome to be. We decided as a group that physical therapists can influence discharge home. At the same time, that was an organizational priority. It was one of the 10 drive metrics for Cleveland Clinic that year, was to help more patients discharge home. So it, again, had that organizational and clinician alignment. This outcome was also we felt like something that required physical therapist interventions for some patients in order to achieve. So it met all of the criteria. There are plenty of models that exist and have been published to differentiate discharge home from patients who can't discharge home. But what we needed was something that could drive a clinical decision. So what we ended up doing was for each patient, we calculated the probability that the patient would discharge home with daily PT and a separate probability for discharging home without daily PT. That gave us some difference in the probabilities that we could then say, okay, so what's the probability threshold that we consider important that would prompt us to prioritize that patient in our care? So having made those decisions, we also needed to consider what are the variables that are important to the model. And Mary talked a bit about this. There are things that matter to clinicians that help them make decisions about who should I prioritize for care and who do I think can go home. So our learning community was key in helping us identify what are those variables. Brittany Lappin, our statistician, was able to check those variables in the statistical model, make sure everything made sense from a statistical approach, and we landed on 8 specific variables that represented constructs of function, pre-hospital function and current function, characteristics of the patient's home environment, and characteristics of their hospitalization, including their service line. That's what we needed to make the data work for us. So then we needed to design the tool, which was our next step. So I'll present what that looked like in the next 3 slides. This group is also in charge of developing the implementation strategy to our peers. How do we want to roll this out across these 3 hospitals? I won't have time to talk about that today, so I would reference that published paper that I cited on the slide before. So here's the basic mechanism of the PT pencil. The therapist does their work. They see a patient, they start their documentation. In the background, the electronic health record is running the PT pencil algorithm that we gave it. As soon as the last variable it needs, the last of those 8 variables it needs is entered in and recorded in the electronic health record, it then runs the algorithm, calculates those probabilities, and determines if the threshold was met that we gave it. So yes, the threshold was met, or no, it was not met. So again, the therapist doesn't even know this is happening at this point. They're just doing their normal work. But what happens next if the answer is yes to this question? The therapist gets this alert on their screen, this best practice advisory. This patient has a higher probability of home discharge with daily physical therapy. Would you like to see them tomorrow? This is a clinical decision support tool, not a clinical decision-making tool. So therapists choose then, do I like this recommendation or do I not? They can even dismiss this and say, get this off my screen, I don't want to think about it. Or they could say no, and we gave them some reasons that they might consider saying no. But if they say yes, we talked yesterday about making things fit into the workflow. So one of the things we did, this is a required field for the therapists to enter the next PT session date. We had that row in their flow sheet automatically fill in with tomorrow's date if they said yes to this BPA. So it was just one less step for the therapist to have to worry about. We also built in this patient list view with a PT pencil indicator. So a green dot next to your patient's name in your list meant this patient was flagged for PT treatment the next day. A red dot meant that the algorithm ran and is not recommending PT treatment the next day. Anything blank meant that that patient didn't meet the criteria we had drawn around the PT pencil algorithm running. So in my last couple of minutes, let me briefly share the results of this. We implemented this in a pilot stepped wedge design across these 3 hospitals. So essentially hospitals and time were our controls for this, where we looked at when therapists had access to the PT pencil versus when therapists did not have access to the PT pencil. We used the REAIM outcomes framework to guide our evaluation here. REACH was the number of people reached by the PT pencil, both patients and therapists. So if you look at the patient level information here, you see that there are 12,303 unique patient admissions where the PT pencil flagged at least once. Or sorry, where the PT pencil ran the algorithm for them at least once, but only 1,505 of those patients were ever flagged. So only about 12%. So imagine this with me. You've got a list of 20 patients. Let's say maybe 10 of those, the algorithm never even ran, so the indicator is blank. So for the other 10 patients, 8 or 9 of them have a red dot, meaning this patient is not indicated for daily PT, and only 1 or 2 have a green dot. That's what we wanted. We really wanted to target patients that we felt could benefit most. We weren't trying to overrun therapists with more patients to see. Effectiveness, I'll talk about very briefly. We measured this in terms of discharge home, readmission, and hospital length of stay. Adoption, we measured by the dismissals of that BPA. So the therapists who didn't care enough about the BPA to even pay attention to it. Fortunately, about 93% of the time they said yes or no. And then implementation, we measured using some EHR data. We also conducted 3 clinician focus groups and had our clinicians fill out surveys. Unfortunately, won't have time to present that today, but there are papers forthcoming, I promise you. So if we look closer at adoption, therapists said yes to the BPA 48% of the time. They said no, not the goal, 34% of the time. Our focus groups revealed some of why that was the most common no response, and we actually learned that the therapist and our understanding and the therapist's understanding of that reason was not the same. So that was a bit frustrating, but it was still informative, and this data was still informative too. In terms of effectiveness, again, our primary outcome is discharge home, and we looked across our primary trial where we did see an effect in discharge home of 74.1% versus 69.2% in the hospitals where we saw more patients discharged home in the hospitals where PT pencil was accessible. However, in our regression analysis, this was not statistically significant. Last slide, Linda, I promise. So from that, we then did a subgroup analysis, just the patients that had a flag, and then the PT pencil recommendation was followed versus not followed. So when the PT pencil recommendation was followed, meaning the patient was seen the next day as the recommendation was, 49.5% of those patients discharged home, compared to only 44.1% of patients who discharged home when the recommendation was not followed. In our analysis, this was statistically significant with about 43% greater odds that patients would discharge home when it was followed. Lest we forget the actual purpose of this, which was not me sharing the results of this study, these are the keys again that worked for us. And I really believe that as we continue to focus on these keys, we'll continue to be successful using data at the clinician level. Thank you.
All right. Well, I have the somewhat daunting task of giving the last formal presentation of what's been an incredible 1.5 days. In the past couple of days, you guys have seen the process of selecting data, accessing that data, analyzing that data. And today, this morning's session is focused on using that data. And we've gone from an institutional level, and you guys, congratulations, have arrived at the patient bedside. So we've heard about data lakes, we've heard about algorithms, and today we're going to talk about a good old paper and pencil tool that's used at the bedside but informed by patient-centered data. I would be remiss not to acknowledge Dr. Jen Weaver, whose work is underlying this presentation today, and who is enjoying her newest family member. It appears my animations aren't working, so you're just going to have to forgive me that this is a little bit covered. Maybe I can go back. Nope. Okay. I'd like to start my talk by telling you guys a little bit about the person-centered measurement framework. I'm sure this is familiar to many of you, but this person-centered measurement framework was developed by the American Institutes for Research with support from the Robert Wood Johnson Foundation. And this is a framework that tells us that patient-centered measurement should be transparent to patients at the bedside and their family members and loved ones. It should be co-created with those stakeholders, including clinicians and patients and their loved ones. It should be holistic, so it should take into account that the person is more than just the data that's in front of you, and then it should also be clear and timely. It should come back to the patient at the bedside in a way that they can understand in that moment. And I would argue, this was supposed to come in a cool animation, but it didn't, that collecting person-centered data is particularly important in rehabilitation for patients who cannot speak for themselves. Patients who can't tell you with the patient-reported outcome measure how they're feeling, it's particularly important that we collect person-centered clinical, clinician-rated outcome measures at the bedside. And the population specifically that I'm talking about today that cannot speak for themselves is patients in disorders of consciousness. Disorders of consciousness involves prolonged marked difficulties with arousal and awareness in patients after severe traumatic or non-traumatic brain injury. And these states include coma, unresponsive wakefulness syndrome, and the minimally conscious state. And the Coma Recovery Scale Revised is the reference standard bedside assessment of neurobehavioral function for patients with DOC after severe brain injury. The Coma Recovery Scale has been subjected to numerous psychometric analyses, and it's a strong tool that can be used by clinicians at the bedside. But there are some limitations of the CRSR, and that is, that particularly includes the way that it's scored. So the CRSR is comprised of 6 items: communication or motor verbal, arousal, motor, visual function, and auditory function. And each of these domains is scored on a different rating scale. For example, the motor scale is scored on a 0 to 6. Visual function is scored on a 0 to 4. Communication is scored on a 0 to 2. And what do we do with these numbers? Well, typically in the clinic, we add them up on a 0 to 23 scale. But the problem with this approach is that it produces ordinal scores. So we kind of know that a 1 is better than a 0, an 11 is better than a 10, but we don't really know how much. And these scores range from 0 to 23. These scores are difficult to interpret change across serial assessments, which is considered standard of care for this population. And it's difficult to explain patient progress to family members. So it's not comprehensible and timely as the patient-centered measurement recommendations suggest. So I would argue that it's not person-centered in the 0 to 23 format. So what did we do? We applied the Roche measurement model to calibrate the CRSR items and rating scale categories along a single 0 to 100 equal interval scale. If this were section D, I would have a lot of fun telling you all about the analysis process here, but I'm really going to focus on what this looks like and how we actually used this information. But I will tell you a little bit about the analysis. The original study included 262 patients in post-acute rehabilitation after severe traumatic brain injury. And we calibrated, using the Roche model, each of the 6 items with their individual rating scales along a common 0 to 100 scale. So I know this is pretty tiny, but what you can see here, for example, is on the communication subscale, or item, as we call it in the Roche model. A 1, for example, corresponds with a equal interval score of about a 70. You can see by looking from the little X on the left to the little X on the right that really represents a range of neurobehavioral function that's somewhere from about 60 on the 0 to 100 scale to about an 80 on the 0 to 100 scale. So that's the basic premise of this tool, which is called a Roche keyform. But the Roche keyform is not enough on its own to be person-centered measurement. It is more comprehensible, I promise, but it doesn't get you all the way to person-centered measurement. So the recovery ruler is a tool that incorporates the Roche keyform and is designed to facilitate better conversations between clinicians, team members, and family caregivers. It features the Roche keyform in a major way, with also added cut points developed using Roche regression model to show transitions between states. So approximately where the patient gets from the unresponsive wakefulness syndrome to where they're more likely to be in the minimally conscious state. And on the bottom half of the recovery ruler, clinicians are able to capture additional information about the patient and the assessment scenario, making this a more holistic and patient-centered tool. And it is this information that has been considered to be valuable not only to the clinician, but also to their family caregiver at the bedside who really needs to understand this data. And I want to highlight that it's particularly important for caregivers of people in disorders of consciousness to be able to understand this data. People with disorders of consciousness can live for decades in that state at times. And their loved ones are their most major advocates. And it's incredibly important that they are involved in the rehabilitation care and decision-making, and that they are able to understand how their person and their loved one is progressing on an individual level. In addition to developing the recovery ruler, we also examined indices of responsiveness. As I mentioned, serial assessment is the standard of care for this population. So it's particularly important that we can understand, is change on this 0 to 100 scale using the coma recovery scale revised? Is it actually meaningful, or is it due to measurement error? Can it be attributed primarily to measurement error? So indices of responsiveness that I'm going to talk about today help us interpret change between assessments for individual patients. So the standard error of measurement is really not an index of responsiveness. It's probably familiar to most of you, but it's the range around the patient's observed measure in which their true measure likely lies. And then similarly, the minimal detectable difference is the amount of change across multiple assessments or between groups that exceeds measurement error or shows true change. In a study of 180 participants in DOC who were measured 4 weeks apart, we found a standard error of measurement of 4 units and a minimal detectable change of 11 units. And again, this is using that Roche transformed scale, the 0 to 100 measure. And then a secondary study with 776 participants showed that time interval between assessments does not influence the minimal detectable difference. So as close as 1 week apart, we can use that 11-unit difference to say that across 2 serial assessments, the patient has or has not made change beyond measurement error. All right, so now we're really at the bedside, and I'm going to give you a case scenario using our favorite clinical case scenario, Jared. He's a 28-year-old man who sustained a brain injury after a fall from height. And on his first day in post-acute rehabilitation, he was assessed using the coma recovery scale. He obtained a score of 0 on the communication scale and 1s on all the other scales. Some quick math, adding that up tells us that he has a CRSR raw score of 5, which can be transformed on the 0 to 100 scale to a 34 units. Okay, so it's about a week later, day 8 in rehabilitation. His communication is still at that 0 level, but he's progressed on auditory, visual, motor, and arousal, and he's at the same kind of 1 level for verbal and oromotor. Adding those up, we have a raw score of 9, which corresponds with a unit score of 47 on this transformed scale. And then when I make this presentation for our clinical partners, I actually have them do this math themselves, but I won't subject you all to that. But on day 1, his observed score was 34, and on day 2, which is day 8, I'm sorry, his observed score was 47. So we can calculate the true score range by going 4 units on either side, and for both of those. And then let's see, 47 minus 34 is 13 units. So he has exceeded the true change using that minimal detectable difference with a 95% confidence interval. In an AOTF funded study, we've been looking at the implementation strategies for actually using this in the clinic. So this is a 6-month trial of the recovery ruler at 4 inpatient DOC programs in the United States. And we conducted regular surveys examining adoption, perceptions, and barriers and facilitators to using the recovery ruler. We found about 41% implementation. So every time a clinician gave a CRSR, did they use the recovery ruler or did they not use it? And we found that was about at 40%, kind of higher earlier in the study, tapering off a little bit towards the end, which is not completely unexpected. But what we're really interested in knowing is, why did the clinician use it when they used it? And why did they not use it when they didn't use it? We found that the most major barrier that clinicians reported was that it was difficult for them to change their ways. And the qualitative interviews supported this. The clinicians with extensive experience in DOC especially felt that they did not need the recovery ruler to understand and interpret the CRSR. But we didn't hear that from about 70% of clinicians. So a lot of clinicians felt that this was something that they were willing to incorporate into their practice, even though it was different and provided something different from what they were already doing. In terms of facilitators, 80 to 90% of clinicians found that the recovery ruler layout was attractive, and they felt that it provided a good starting point for conversations with family members and clinical decision-making. And I think quite a few of us this morning have talked about data as a conversation starter. So I think that's an interesting synthesis. The qualitative interviews also supported this. The clinician said that the primary use of the recovery ruler was to make data more accessible to families at the bedside. So the primary reason that clinicians didn't use it when they didn't use it was because there wasn't a family member or a loved one at the bedside at that moment to hand it to go through it with and hand it to. We also did some quantitative surveys of acceptability, appropriateness, and feasibility. And at the end of the 6-month trial period, our clinicians were very kind and rated each of these constructs above a 4. But I'd like to focus on a couple of clinical vignettes using the recovery ruler. So in this first story, a clinician, I won't read this aloud, but the clinician tells us about using data to support a difficult conversation with a patient who was not progressing in rehabilitation. And the clinician wanted to have a conversation where they set family expectations about prognosis with this patient. And they said that the family had a tough time because they were all trying to educate them about that more poor prognosis, but it's hard to see that. And so they used the recovery ruler as a clinical conversation starter to have that visual support, she called it. And she said, I think it made something that, when we call it ambiguous, right, feel more concrete. And then another quick story that a clinician told us about data supporting better clinical decision-making. Using this 0 to 100 scale, the clinician was able to see that the visual scale specifically was lagging behind all of the other scales as they were progressing and the patient was making progress. And they used that to share with the medical team that they suspected potential cortical blindness. And then in their clinical practice, they didn't use visual stimulation with that particular patient as heavily as they might have otherwise. So So what are our next steps? We are in the process of mapping the data from clinician interviews to the theoretical domains framework to help us develop implementation strategies for larger scale implementation of the recovery ruler. And we also plan to collect data about family caregivers' perceptions of using the recovery ruler at the bedside. And then finally, in a future clinical trial, we hope to investigate how the recovery ruler can be part of improving shared decision-making among clinicians and family members of patients with DOC. These are my references. And I'd also like to acknowledge our clinical partners in this study, which include Spalding, some of whose have representation here, Tier Memorial Hermann, Craig Hospital, Shirley Ryan Ability Lab, among others. So could not have done this without the support of the incredible clinicians and facilities that we work with.